At this time, I would like to introduce Brad Dobson. Brad Dobson has been a licensed mental health and clinical addictions counselor since 2011 and a pastoral counselor since 2015. His experience includes working with drug court, community mental health, college counseling, private practice, adjunct, undergraduate, and graduate teaching. His areas of expertise include chemical addiction, grief and loss, mood disorders, young adult issues, suicide assessment, and faith exploration. You can find him at Providence Behavioral Health Group in Fortville. Our second presenter is Dr. Lanny Jones, is a licensed clinical psychologist, early intervention provider, and co-owner of Providence Behavioral Group. Her areas of expertise include the assessment and treatment of neurological development disabilities such as autism and ADHD, in addition to challenging behaviors, feeding difficulties, and mood disorders. She also conducts therapy with children, adolescents, and adults. She received her doctorate in clinical psychology with a concentration in children and adolescents from the University of Indianapolis. So at this time, I'd like to turn the presentation over to Brad.
Actually, I will take it from here. Thank you, Laura, for that introduction. So I think now more than ever, this topic is even more pertinent given that we're in the midst of a global pandemic, political unrest, racial tensions with everything going on. And so on this first slide, just looking at some of these stats of depression, I intentionally put pre-COVID because regardless of the current situation or where we are, depression is always one of the top mental health concerns across age groups in America. And so going back to 2017, one of the major research studies in the National Institute of Mental Health, their findings were that for adolescents, so ages 12 to 17, about 13% disclose experiencing a clinical depressive episode in the last year. A lot of the research shows anywhere from 10 to 20%. So as much as 1 in 5 adolescents are saying, hey, I've been experiencing these symptoms to the point that they're somehow interfering with my functioning. Unfortunately, typically more than half receive no treatment. So they don't ever have a conversation with some type of therapist, counselor, mental health provider, family care doc. But 1/5 though do have that connection. It could be a school counselor, it could be primary physician, and are seeking medication as well. And then when we look at the stats for adults, typically most research shows somewhere around the 8 to 13% outside of COVID time. So we're talking what our usual is outside of 2020. Because I know 2020 has been filled with so many different exceptions for everyone. Typically, 1/3 of adults don't seek out treatment. There can still be a lot of stigma associated with that, or just the, how do I find the help I need? What kinds of questions do I ask? Or the practical aspects of seeking services of, do I have insurance coverage, or is there a provider in my area? And so there can be a lot of barriers to treatment, even for those who do want to seek it out. And on reporting on severity levels, when we were looking specifically at adolescents, nearly 3/4 described their symptoms as severe. So they were impairing somehow their academic functioning, if they had a job, their social relationships, family, and about 2/3 of adults report it's severe too. So there's some level of normalcy that we all experience these symptoms at some point in our life, but then when does it become problematic and start to impact our functioning in our respective environments? So currently in COVID, all it takes is a quick Google search, and there is all types of headlines talking about the family mental health crisis, or depression in children and teens, or maybe the physical impact of coronavirus isn't severe as we thought, but is it the mental health aspect that is even more profound? Same just with the home confinement or stay-at-home orders. During that time especially, there was a really significant increase in anxiety, depression, suicide, which Brad will get more into. And so comparing kind of what did these numbers look like before and in the midst of our current circumstances, a lot of them have nearly tripled. And so Boston University, their School of Public Health, is one of the first starting to put out some new numbers, to some new research into this time, because we're about 6 to 7 months into this. And so they find numbers are nearly a third of adults are reporting really significant symptoms during this time. And this is increases across all demographic levels. So regardless of age, race, income level, relationship status, and we're seeing that those problems are becoming more and more severe as well. So COVID has had quite the impact outside of just the physical piece of it. So social isolation is huge across all age group. So with young ones, for children and adolescents, they have lost out on time with peers and friends. They might be isolated from family members. Maybe family members are high risk, or they can't, be around their grandparents as much. There's been a lack of access to support or coping strategies, stress relief. I know early on, a lot of individuals I'd work with, and they'd be like, all my coping strategies are gone. I can't go to the gym. I can't hang out with friends. Like, what do I do now? Everything I turn to is changed. There's work changes. So maybe that's you've lost a job, you've been furloughed, or you're now working full-time from home, trying to be teacher and caregiver and parent and good employee all at the same time. All those educational changes, not only if your child's doing e-learning or if they're in person, but so many corporations are like, okay, Mondays and Wednesdays, you're in person, Tuesday, Thursday, you're at home, or every other Friday, you're doing this. It's just a constant flux of changes. A lot of financial strain with that in terms of job changes, school changes, family stress. We're seeing that just consistently across the board, and then health concerns. And so maybe that's not about COVID specifically, but if you had an underlying condition and you had a job loss and now you can't afford your medication, or you were too concerned about catching COVID to go to your doctor and get that checkup or go to the ER, whatever that looked like. And so now leading to all this increase in not only depression symptoms, but anxiety, stress, worry, fear, loss, all those things that play into that. And so one of the hallmarks when we're talking about depression is typically sadness. That's oftentimes what most people think of, but there's also a sense of hopelessness, of emptiness. And we're really looking at, is there a change from previous functioning? And so one of the other hallmarks is a loss of interest in activities. But if your adolescent's just an introvert and they're okay and they've got their 2 to 3 friend groups and that's always been good for them, then that's not going to be a change in functioning if they're still staying with that. But if you have the adolescent who's the total social butterfly, they like a big friend group, they're always going out, and all of a sudden you're seeing that decrease and they're pulling back, that might be a sign or a symptom that there's something going on. We also look at differences in changes of sleep. So either sleeping too little or too much, changes in appetite, feelings of worthlessness, guilt, everything is their fault, recurrent thoughts of death, which Brad will get into more and touch on the suicide piece of it, difficulties thinking, concentration, mental fatigue. So oftentimes when it gets brought up that there's some inattention or focus difficulties, the first assumption or go-to is this ADHD? But there's actually a lot of things that could be impacting a child, an adult, it doesn't really matter age, their mental capacity. So it could be anxiety, it could be depression, it could be stress, it could be lack of sleep, even nutrition. And so really we need to assess kind of that broader picture and look at what is causing these difficulties with our mental functioning, our cognition and attention, things like that. Irritability. So oftentimes this is like a hallmark for children and adolescents. And I know oftentimes it's hard to differentiate in adolescents because it's like, when are they just being moody or irritable? And that's just like a normal adolescent. And so once again, thinking about that change from previous functioning. And so oftentimes in children, depression expresses itself in terms of behavioral concerns or challenging behaviors. So maybe they're having more difficulty following parent instruction or parent direction, or there's been a change in their behavior from their previous functioning once again too. So those behaviors may really be telling you something. Maybe your child doesn't come across as just being sad, but maybe the behaviors are speaking in place of that. So how do we differentiate here clinically? And so we focus on what's the severity and then what's the duration. So how long is it lasting? And there's kind of two general categories we're looking at. And so for major depressive disorder, it's 5 or more of those symptoms present during the same 2-week period. And so when we think just in terms of 2020, we're pretty far into it now, even 6 or 7 months into the global pandemic. And so that's really a short time in the midst of everything. And so when that research is just starting to come out and why rates are tripling, because it's a low threshold in terms of time. But once again, we're looking at, is it causing significant impact? Is it, impacting someone's ability to work? Maybe there's so much mental fatigue or difficulties with focus, they aren't doing their job as well. Is it impacting their relationships around them, their family, friends, things like that? And then the second major one is persistent depressive disorder, so dysthymia. So this is kind of like that low grade fever. And so this is only 2 or more symptoms, but for adults, it's 2 years or more. And then for children or adolescents, it's 1 year is the threshold for that. And so some of the risk factors, family history plays a large part because we know genetics are an important piece of this. A loss of a loved one or a relationship, and that loss doesn't have to be a death. And so this could be changes in caregivers, loss of interaction with beloved coach, teacher, somehow where someone significant is no longer in their life for whatever reason. Prolonged stress. So I would say this is one of the most challenging issues to the current situation. And I often hear from people is there's just no end in sight. When you're going through a tough season or there's something specific you have to get through, it's like, okay, I just got to get to this point or get to, the next stopping point. Whereas here, everyone's like, I don't know, we're going back to school. I don't know what's going to happen with flu season. Is this even going to be over by 2021? There's just so much unknown that makes it even more difficult to cope with. Abuse, neglect, trauma, chronic illnesses, and then other mental health or diagnoses. And so especially for the student population that already had a diagnosis, like maybe those with ADHD, anxiety, autism, students who really needed even more so that predictability, the structure, the routine, who thrived on that, which all kids do to some extent. And so now those who already needed additional supports, maybe they had a 504 plan or an IEP, and they aren't getting those same accommodations, and their school schedule is shifting every single day, they're struggling even more. And so really checking in, getting more supports with them, because the average student is struggling right now. The average parent is struggling right now. And so making sure even for those who already had a diagnosis going into this, they are at an even greater risk of continuing to struggle with that. And so I also added grief on here too, because grief isn't just about death. and loss in that facet. And so for children, adolescents, any students, school is their life. So if they were looking forward to that sixth grade graduation or, that conference championship game that they've been, training in the off season all year, or the drama production, the field trip, whatever it was, that is what's most important to them. So I think sometimes as adults, we downplay like, oh, in the scheme of things, it's not that big a deal. But for them, that is loss. For them, that is a type of grief that, they're not understanding the situation. And even as adults, we don't, but they're trying to grapple. They're angry about it. Why can't I go to school? Why can't I be with my friends? Why did I have to, miss my baseball games and all of that? And so recognizing and validating what's been their experience and that they do have loss just in the midst of this current situation. And so now I'm going to turn it over to Brad, and he's going to touch more on the suicide piece of things.
All right. So it's a perfect segue because grief is one of my areas of specialty. And in one of those questions that we ask as we're screening in suicide is there a triggering event, a recent trauma or loss? And we have to start thinking more broadly about what loss means. It's not just the death of a loved one or a relocation in job or anything like that. We have to start thinking about, is your financial status changed? Has there been a health risk? Is there a loss of perceived control? So much has changed and people have a lack of control over what's going to be next, that's now a perceived loss. Not only careers, meaning, purpose, academic, sports careers. And we're not just talking about Pee Wee leagues. We're talking about college athletes that are now saying, there are coaches that are saying it's going to take 4 or 5 years before they get to the same level of competition that they were pre-COVID, because we've had such a degree of time that people haven't been able to compete and to hone those skills. And now we've got people that had scholarships that are being questioned, or now they're competing against people that were redshirted that are now 6th-year seniors. And they're really wondering, well, do I go towards this when I'm not going to be playing for another 2 years? So much has changed for high school, college athletes. And then obviously the social isolation piece being a loss in that social connection. Then we look at it for adults, workplace camaraderie. The idea that you're now working at home, you don't have that escape of actually seeing adults, having adult time, especially if whether you're a single parent or co-parenting, and then you have that commute time. You've lost your commute time if you're working from home. Sports, recreations, all those types of leagues, a lot of things have been closed. We don't have the softball leagues, all the intramurals, the co-ops that we used to have. A lot of the churches are just now starting to regroup, and a lot of those programs that they offered have been gone for 6-7 months. As Lainey talked about, loss of coping outlets. Then we have, in addition to another demographic, the lack of closure that people are experiencing in grief for delayed funerals. We have people that have lost people 3, 4, 5 months ago, and they still haven't had formal events to achieve closure because they didn't want to have a gathering where they couldn't get people together. And I have many people that I see lately that are just now recently having celebrations of life or actual funeral services. Then we have reduced visitations in long-term care. We have a lot of people that are only permitted to visit once a week, or at least a lot less frequently than they were able to visit their loved ones prior. We're starting to see policy changes in long-term care facilities from a legislative point of they're trying to be more compassionate for these changes, and they're trying to change policies, but these have been going on for 6 months where these people are concerned about their loved ones, and they're not allowed to visit, or they're allowed to visit through windows or other barriers. And then we just have that reduced work-home boundary. That's a loss in itself, because when everything's meshed together, what we're seeing in statistics is that people we're working from home and have more flexibility, but you're also working more hours because it's right there, it's accessible, and there's the lack of boundaries. And it's like we tell college students, you don't study in your dorm room on your bed. That's for sleep. Well, as adults, when you're working from home, you don't have that boundary anymore, and it's blurred. And so, again, another loss. So we have to start thinking about loss in a broader term as it relates to how it plays into grief, depression, and ultimately suicide. We'll go to the next one. Okay, so I bring up Kevin Hines, if you're not familiar with his story as a suicide survivor, it's important because it goes into the idea of how impulsive is suicide. It is not an impulsive process. The idea of suicide is something that many people that attempt have thought about for a prolonged period. But the act of suicide is impulsive. When they actually come to that moment that they say, I want to do it, it's an impulsive act. And his is a great story because on September in 2000, at 20 years old, he went to the Golden Gate Bridge, took a bus there, told himself that if just one person would come up to him because he was distraught, crying, he looked like he was in distress. If just one person comes up to me and says, how are you? Are you okay? Is something wrong? That he would have a restored faith in humanity. And when he got there, his story is that somebody came over and he thought, oh, wow, somebody's going to take an interest in me. They asked him to take a picture for him despite his condition. And he's like, okay, that's the final straw. Literally, humanity is not worth it. I'm going to step over the railing. But the moment, that impulsive act that he had in deciding to do it, the moment he let go of the railing, he said he wanted to live, but it was too late. And so he did fall. He did survive, though, had a crushed spinal vertebrae, broken ankle. He was diagnosed bipolar and it was pre-existing diagnosis, but he fell 240 feet in 4 seconds, reaching 75 miles per hour. That's crazy to think about, and how quickly 4 seconds goes by, but he survived. And so he goes around today and he's got a great speaking platform to say, how do we recognize all the precursors? We talk about different kinds of suicidal ideation being passive or active. And so he's a great story, and I really encourage you to look at his resources that he puts out there, Kevin Hines, whether it be this documentary that he promotes or his speaking series or books, but the idea of what suicidal ideation looks like and how the simplest gesture can literally make the difference between somebody taking their life or trying to take their life or accepting help. And it's a great story and a resource that I would encourage people to look at. So we'll go to the next one. So real quickly, suicide stats. These are a little bit older, but these are more recent. CDC reporting that suicide was the second leading cause of death for ages 10 to 34 in 2017. We're talking about 10-year-olds to 34-year-olds. And when we talk about, we don't really know how to interpret a lot of emotions, as Lainey talked about. Are they just being dramatic, or is this something to be serious? You always take it seriously, because we talk about young men versus young women, and that's a little bit towards the bottom. Men are more likely to use weapons and vehicles to attempt suicide. Females are more likely to attempt overdoses and self-harm behaviors. So we have to take it seriously, because particularly in our male suicidal ideation victims, more often than not, they're going to get it done. And that's an unfortunate statistic, which is the silver lining for our female clients, is that there is an increased likelihood that we'll at least have an opportunity to get them to the hospital to either pump a stomach or perform medical procedures to get them back, thanks to the likelihood that they've overdosed versus a very, very life-altering, lethal attempt with weapon or vehicle. So we have to recognize 10 to 34 is the second leading cause of death, and taking this very seriously. Research shows that 9 out of 10 individuals who attempt suicide have a history of mental illness or substance abuse, making these extremely important factors. Specifically substance abuse, because that's my absolute specialty. We talk about the number of people that have an addiction and a comorbid mental health issue. It's extremely high, okay? And we have to recognize that whether they're in active addiction or they're going through what we call PAWS, post-acute withdrawal syndrome. We talk about post-acute withdrawal syndrome. They are likely to have a mood issue, usually depression or anxiety, okay? And so more commonly depression, as they're coming off of the drugs and their brain is trying to find that new balance in chemical balance. So with that risk and recognizing that they don't have the same level of enjoyment, because through recovery, most of my addicts are coming off of an elevated dose of dopamine. Dopamine is the gotta have it, excitatory neurotransmitter. And so that's what the drugs were providing them artificially. And when you don't have that anymore, your brain says, things aren't as enjoyable. Life's not as enjoyable. And then if they don't get enough dopamine, they don't get enough serotonin. Serotonin is the got it. It's the contentment that follows dopamine. And so if you're not getting one, you're certainly not going to get the other. And so we see this at a very high rate in active addiction, but also in early recovery, especially that first year. And we have to take that into consideration into when you don't feel like there's any enjoyment and you see that it's hard to see that light at the end of the tunnel because recovery is such a hard path. We take that into a stronger consideration when we're assigning suicide risk. And so we talk about suicide as a risk equation, that there's these things we call protective factors and risk factors. And so taking into consideration, what age are they? What gender are they? What struggles have they experienced recently? We know that our greatest risk population specifically is our older Caucasian males. They are of our highest risk population for suicide attempts. And so we look at, take all those things into consideration as we're assessing risk for suicide. We'll go on to a little bit more of those factors with the next one. So warning signs: noticeable changes in eating or sleeping habits, unexplained, unusually severe, violent, or rebellious behavior, withdrawal from family or friends, sexual promiscuity, truancy, vandalism. A lot of these things sound like on some pretty common behaviors we see in teenagers. Drastic personality changes where we don't know who's coming out of the room tonight. Talking or writing about committing suicide or even jokingly. That's a big one. We start finding journals, or we start seeing writing assignments and creative writing or things with themes of death, suicide. Those are things to start taking seriously. One of our later stage risk factors, giving away prized possessions and items, that's something that we take with a greater level of risk as well. That if they're actually physically giving away items of value and meaning, this is a later stage behavior of suicidal ideation. They've thought through it. They've assessed value to items. They've assessed who they want to have them. And then they take on the additional act of actually giving that to someone. This is what we consider a later stage risk. And then lastly, agitation, restlessness, distress, or panicky behaviors, as in kind of like that antsiness of they're ready to do it. And the biggest thing that I tell the survivors of individuals that had a person they cared about commit suicide is that if that person has chosen to do it, there was nothing, if that person was alone, if that person, sometimes they send text messages goodbye, sometimes they leave notes and they haven't shared it. Sometimes they don't say anything at all and they just leave journals or other things, Facebook messages, and they're doing a better job of reaching out in those examples of trying to get emergency services, people that are doing that. But for the survivors, we have to recognize what we can and cannot control. And what we do is we provide resources, we provide support, we provide clarity for people that are not thinking clearly. And you have to recognize, to be in that suicidal state, you are no longer thinking rationally. You're not. There's nothing rational about self-destruction. It defies our survival need. And so you have to recognize what is the state of mind that this person is in, and what's your ability to intervene or control or have any influence over them when you're not physically with them. And so I deal a lot with people that are the survivors of it, and not in addition to the people that have attempted, but recognizing what's your level of control in these types of situations. But these are often suicide warning signs. I do want to talk about some of the protective factors and the risk factors for passive and more active signs in addition. I think that's the next one. Yeah, the passive suicidality. So what I mean by passive suicidality, these are some common passive statements. I don't want to be around anymore. I don't belong anywhere. And I use that one because our greatest need is love and belonging. That's what drives us in so many things, whether it's consciously or subconsciously, is that I want to belong. And if I don't feel like I fit in anywhere, there's nowhere for me, what's the point? That's a dangerous statement. No one loves me. Again, love and belonging. Those are our greatest needs. That I'm unlovable. So what's the point? You'd be better off without me. These are all passive statements that don't show the level of intent. As many of you probably know, we talk about what's the plan, what's the level of intent, what are your means to get it, how much thought have you put into it. We talk about those kind of general risk assessment, but much of this lies underneath that, okay? And then passive suicidality can be reckless driving, of just trying to tempt the odds, as they say, that I'm just going to drive recklessly, and if it happens, it happens, even though they are playing a role in it. Medication misuse. We see this with our diabetics, especially my teenagers, where they become reckless with their insulin. They stop taking it as they should, or they're taking it excessively, and very much putting themselves in great danger as well. Those are actually active, but the very beginning of that, they oftentimes just say, oh, I forgot. It's kind of a passive subconscious attempt, and they're not doing it in an overdose type of manner, but they're like, oh, I just forgot. And people will start to recognize the way they present physically, and that's their cry for help. Writing with death themes, as I said earlier, whether it be in school or journals, just using those themes. Those are passive suicidal cries for help. Depressing, angry music. I know there are plenty of populations where that's popular. That's just popular music, but it's also something to pay attention to, because they're taking it in. And as they take it in more and more, how much are they internalizing it to their motives and behaviors? And lastly, self-harm behaviors. A lot of people misunderstand what cutting, burning, choking, those forms of self-harm are, whether it be picking or hair pulling. It's not an attempt. It is a cry for help. It can mean a lot of different things. For some people, it's to feel something other than numb. For some people, it's the excitation of seeing blood. There's a lot of different motives for people in their self-harm behaviors, but it is not typically an act of suicidal attempt. And so we try to differentiate. And then the next one, I'll get into the active more. Well, I apologize. I missed one. So active suicide attempt is where I've got a plan, I've got a place, I've got the means, and I'm implementing. And so that's the difference between the passivity of those statements and those early warning signs versus we say active attempt is I've got a person that they've collected the pills, they've found a weapon, they have found the means, they have planned it out, and they're ready to execute. So that's why we talk about getting people into the hospitals of, are they going to accept them under passive conditions? No. And so they have to be an active risk to their self or others to be hospitalized. So what do we do with all of this? Prevention. I always say open dialogue is our greatest resource. The idea of how do we not give statements of concern versus invitations of questions of how can I help? What's going on? Just help me understand. Text communication is horrible. I don't encourage it just in general. If we could kind of get rid of text messages as a whole, I'd be fine with it. It's horrible communication. And I really encourage the face-to-face. You need to see their body language. You need to be able to see, are they going to look at you? So we predominantly speak non-verbally, not with our words. And how do we build trust? You know, how do we build trust with those people versus looking through their phone at certain text messages? I mean, there comes a point where if you're truly concerned, and I understand that you're going to take that initiative to make sure that they're not saying goodbye or something like that, in those moments it makes sense. I get it. But in general, those are things that are going to push people away and leave them more guarded. How do we be more intentional about one-on-one time so that they don't have to talk in groups around family or friends or others? How do we be intentional about requesting that, building that time in one-on-one? And lastly, do we need counseling? Do we need medical treatment? Do we need a psychiatric evaluation? And the point of counseling is to help a person see what they cannot see. We are in the way of seeing what other people see. And so that's what counseling does, is we help people get past all of the defense mechanisms and all the things that we do to survive, but oftentimes in unhealthy ways. And that's what we're trained to do. So I always say a sense of belonging is the greatest protective factor in preventing suicidal behaviors, because that is our greatest need, love and belonging. So I think that's our best prevention. And the next one would be our info. If there's any further questions, this is our information and you are welcome to reach out. Also, we have some crisis information down there that's also great resources.